Welcome to Image the Check-In, the Image podcast lifting the lid on women's health one honest conversation at a time. Image the Check-In is empowered by Boots and sponsored by Samsung and Waterstone Clinic. I am your host, Ellie Balfe, and in each episode I sit down with some leading medical minds to explore the realities of our health across every decade. From hormones to heart health, this is your space to feel seen, heard and supported as you take control of your health span. Because when women are informed, we are unstoppable. Today we're joined by consultant cardiologist Dr Róisín Colleran. Dr Róisín Colleran is a consultant cardiologist at the Matter Private Network and recently led the Women's Heart Summit, a landmark conference for medical professionals focusing on better recognition and treatment of cardiovascular disease in women. In this conversation, we explore why women's symptoms can differ, how hormones influence our risk across the lifespan, and what numbers we should actually know, and how we can advocate for ourselves with clarity and confidence. Dr Róisín Colleran, it's so lovely to have you here today on the check-in. Thank you for being here with us.
Thanks so much for having me, Ellie.
I'd love to go back a little bit and what drew you to cardiology and then specifically into women's heart health, if you could tell us.
Yeah, so I guess cardiology, I loved, during our training, we rotate around lots of different specialties in medicine, and I love the acute nature of cardiology. So the emergencies, the heart attacks, the getting people up to the cath lab, opening the arteries, and you do a lot of your own diagnostics, echocardiogram, and so you do a lot of your own diagnostics and therapeutics. It's quite exciting. So that brought me to cardiology, and my area of interest in cardiology actually is coronary revascularization, so stenting heart attacks, angina. And I guess in recent years I've developed more of an interest, or not more of an interest, but an interest in women in women's cardiology, women's heart health. I think by virtue of being a woman, I see a lot of women are referred to me for cardiac conditions or for cardiac screening. So I guess I've developed more of an interest in it.
Yeah. And would you have thought previously that it was more of a male-dominated area?
I guess this is a misconception among lay people and probably a little bit among doctors. We know that cardiovascular disease is the number one killer in men, but it's also the number one killer in women. So, 1 in 4 of us will die from heart disease. And we're 6 times more likely to die from heart disease than from breast cancer in Ireland. So it really is, very important for women to take an interest in it too.
Yeah.
I think that misconception probably comes from the fact that we tend to present a bit later than men. So on average, about 10 years later than men. And we can present a little bit differently.
Yeah, okay. Which leads me to the fact that you recently led the Women's Heart Summit in January, I believe, which was for clinicians primarily, wasn't it? It wasn't for lay people.
Yeah.
I think it was, I thought that looked very, very interesting. Did that go well? Was it well received?
It went really well. It was very well attended and we had a few hundred more join online. It gained a lot of traction. I think people are developing an interest more and more in this. I think women are taking their health into their hands and taking more of an interest in their health. I think with cardiac health, health in general, probably women are caregivers primarily. We're minding kids, we're sometimes minding parents, we're worrying about our husband and his heart or our partner and their heart. But we're not very good at taking care of ourselves.
Yes.
We're busy, a lot of us are working now and we're juggling all of this other stuff and it's not convenient for us to go to the doctor or get ourselves checked.
Yeah.
I think people are beginning to realize, what, if I'm not around and I'm not healthy to take care of these people in the future, then what good am I?
Absolutely. I heard an analogy the other day that you would take your car in for the MOT or the NCT or whatever if something goes wrong, and women aren't doing that for themselves, for like the full check, the full health check, that type of thing, and it is true. When you think about it, it probably is true. People would get the car sorted before they'd go and do their full check themselves.
We put the health stuff on the long finger. Say, well, I must do that. But there's no deadline. There's no NCT. So
isn't it true?
We kind of push it off,
Yeah, absolutely. And it was actually in that in the summit, there was the keynote topic I was really interested in. So that was called Heart Disease in Women, Under-Recognised, Underdiagnosed, Undertreated, a report from the Lancet Commission. I mean, there's a good starting point. Tell me about that. Why is that so?
Yeah. So yeah, and that was a really good talk from Professor Roxana Mehran from New York, who's the president-elect of the American College of Cardiology, and a tour de force in cardiology as a whole, but also now leading out in women's problems in raising awareness really with this Lancet Commission that she led. Why is it so? I guess it's underdiagnosed, as I alluded to. Women can have different symptoms to men. So I suppose in the setting of a heart attack, we all have this idea of a man on TV clutching his chest with
the Hollywood heart attack.
Exactly, with a central crushing chest pain. And while this is the most common symptom of a heart attack, women can be a little bit unusual and present with atypical symptoms, maybe back pain or shoulder pain or jaw pain, or fatigue and dizziness or nausea or upper stomach pain. So it can present a little bit differently, which can either lead to a delayed diagnosis or misdiagnosis. And I suppose with angina and other less acute cardiac conditions, that can also be the case. Women may not recognize these symptoms as being cardiac. And doctors might not be as quick to recognize these symptoms as being cardiac and refer on. I suppose historically, if we look at trials, and I said my specialty is stenting and blocked coronary arteries and diseased coronary arteries. If we look at trials in that subspecialty, if you look at the representation of women in those trials, it's generally in the region of 25%. So while our guideline recommendations are informed by such trials, really a lot of the data gained from such trials may not be, we may not be able to generalize that to women.
Absolutely.
So we don't really know the ideal treatment all of the time in women. So I think a big take-home message is women are not just little men. We are very different, and we're learning that more and more.
Yeah, it's staggering really, isn't it?
Yeah.
I mean, it's great that we're understanding it more, but it's staggering that it is such a low level of understanding to this point. I mean, is there still a gap in knowledge, would you say, on women's perspective as well?
Amongst women, do you mean? Or
yes, amongst women,
I think so.
About what might be happening to them, or if symptoms are arising, they wouldn't put it down to something cardiac.
Yeah, I think so. Sometimes, I suppose cardiac pain, even when it is typical, it's often it's usually behind the breastbone in the center of the chest, which can be confused with gastrointestinal type, indigestion, and sometimes men and women can sit at home for days with a heart attack and then maybe present because things aren't going away. And with women, I think if you're having unusual symptoms like back pain or shoulder pain, you're not going to be as likely to seek medical attention.
No. So what are the symptoms? If we could run, what way does it present for women in a heart attack, and then get into them?
And I suppose we talk about cardiovascular disease, but I guess the vast majority of that is coronary artery disease or plaque formation, atheroma in the coronary arteries, and that can present very acutely with a heart attack, or can present more subacutely with angina, which is just a fancy name we give for the constricting discomfort in the chest that occurs with exertion when people have narrowed arteries. For the majority of people, both male and female, it will be a central pressure, tightness or heaviness, so not a pain. And patients will often correct me on this. They say, well, no, doctor, it wasn't a pain, it's a discomfort.
Does it come on gradually or come on all of a sudden?
So if it's angina, so the more subacute, it comes on specifically during exertion.
Okay.
And that's a real red flag for us.
Okay.
So if you're getting chest discomfort and it's coming on while you're sitting on the couch, unless it's persisting and getting more severe and lasting more than 15 minutes and you're worried about a heart attack, it's usually not cardiac if it's a fleeting thing, because angina is a very predictable symptom. So people will say, I'm beginning to avoid hills. Every time I get halfway up the hill outside my house, this comes on. I stop, it goes away within a few minutes. I do the same level of exertion again, and the same thing happens. So that can be sometimes not in the chest. It could be in the upper stomach, the epigastrium, could be in the shoulder, the back, the jaw, the neck.
And is that a tightness or an ache, or
usually
describe it?
Tightness or a pressure or a heaviness.
Okay.
Usually some kind of constricting discomfort rather than, so not a sharp pain. And very occasionally a burning, but burning would raise suspicion for more of a gastrointestinal cause.
Yeah.
But if it's happening on exertion, then you're gonna worry more about angina. Some people don't get chest discomfort.
Okay.
And their anginal equivalent, as we call it, might be shortness of breath. So if people are getting very short of breath on exertion, of course, that can be for a variety of reasons. But one reason can be
that
coronary artery disease.
Yeah, okay. But then once they rest and are going about their regular day, they're not feeling anything?
It's generally exertion related. So, I mean, maybe they're doing the hoovering, it comes on, or, you know, they don't necessarily need to be at the gym, you know, it's exertion. And I suppose it can become quite severe where walking across the room, if you have a really severe lesion, can cause symptoms.
Wow. So the difference between men and women in terms of heart attack, right? We'll go back to general cardiovascular health. But, you know, if a man and a woman walked into A&E saying, I think something's wrong, would their symptoms be treated differently? Would they be diagnosed differently because of how they're presenting?
They may be diagnosed at a different rate. It does depend on the symptoms. So I guess if a man or woman walks in and clutching their chest does describe this type of pain, you're going to have a high index of suspicion. But of course, you're going to, you know, people, you know, men are going to be more likely to have that typical pain.
Yeah.
And people are going to rush and do the ECG because we should be doing an ECG in these patients, a tracing of the heart within 10 minutes of presentation. And in a woman, if you've kind of weird or unusual symptoms, you know, if it's in the stomach or somewhere else, people aren't going to be running around quite as quickly, and there can be a slower diagnosis.
So it might be investigated a different way, like different.
Yeah, exactly. Other things might be checked, and ECG will be done, I'm sure, but might be done a bit later.
Yeah, God, that's so interesting.
Yeah. So
tell us, what is the difference? So if you just run us through what women should be watching out for, just in terms of heart attack. So is more of a radiating.
So again, for both men and women, the biggest thing would be chest pain. People have the misconception that it's in the left chest over the heart. It's actually usually behind your breastbone.
Right, okay.
So usually in the center of the chest, usually kind of lower down, maybe between the breasts, but it can be higher up, anywhere between there and the throat. A tightness or heaviness or pressure. If it is a heart attack, people will often say, you know, it's like an elephant sitting on my chest. It's real pressure rather than that sharp pain. There can be associated sweating, nausea, shortness of breath. It can radiate, so it can go from the chest. It can be in either side of the chest or radiate from the center out to either side, not just the left. It can radiate to the jaw or down the arm, either arm, but again, more usually left arm if it does radiate. But some people might just get the arm pain or might just get the neck pain. So it's not always going to be in. And then, as I say, some people can have kind of bonkers symptoms that really are kind of unusual. You know, people can have just pain in the back, the upper back, or I suppose pain in the stomach, or maybe no pain at all and just severe shortness of breath or severe nausea. People sometimes describe this feeling of impending doom.
Oh, wow.
Where they just feel something awful is going to happen.
Really?
Yeah.
And why is it different for women? I mean,
and I suppose that it's important to note that is for men and women, but for women, I'm not sure. I guess we're made a little bit differently, and we just seem to sometimes manifest it in a different way. Chest pain still being the most common, but sometimes these more
just really important. There's other things you need to be aware of.
Yeah.
So
we need to have a high index of suspicion, you know.
Yeah, and that somebody, like a woman sitting at home, if she's experiencing this needs to know when to go to A&E.
Yeah,
right?
absolutely.
Rather than sit there and think it's something else.
Yeah.
You know?
What's interesting is, I suppose, when men and women have heart attacks, what we've learned from autopsy studies, you know, the mechanism of a heart attack. These were all in studies in men, some decades ago, and we have these beautiful histology pictures of a plaque, so a fat-filled plaque in a coronary artery wall with a thin lid or cap over it, and when that cap ruptures, this fat becomes exposed to the blood. Your natural healing mechanism is to clot, like as if you're forming a scab on a cut. And that's what can cause a heart attack, and that's the most common mechanism. If you get a clot in a coronary artery, while it's a healing response, in fact, that's what's going to block it. Because if you imagine a coronary artery is anywhere between kind of 2.5 to 4 millimeters, give or take, doesn't take a huge clot to block off an artery, and then you're completely, the blood supply to the area of muscle supplied by that artery is devoid of any supply. So that's the traditional kind of mechanism of a heart attack that we understand, but that's actually much less common in women.
Okay.
So we know that women are less likely to have a blocked coronary artery, even in the setting of a heart attack. So about 60% of cases of heart attacks without blocked coronary arteries are in women.
Really?
And that can be for different reasons, some of which occur more often in women. So there's one condition, SCAD, or spontaneous coronary artery dissection, where a tear forms in the lining of the blood vessel.
Okay.
And your blood supply, if you imagine your blood is under high pressure, it's an arterial system, and your blood is under high pressure in the artery supplying the heart muscle. If a tear forms, blood can get in to that false lumen, and that can compromise the blood flow in the true lumen, in the true vessel. And that can cause, reduced blood supply to the heart muscle, and that can cause a heart attack. 90% of those cases are in women.
Are women? Why?
Great question. And in fact, in younger women, so predominantly in women in their 40s and 50s.
Oh, wow.
Women without so many traditional risk factors for coronary disease, so they don't necessarily have the cholesterols and the blood pressure and the diabetes and the smoking. Kind of in the perimenopause era, so you have to think that there's a hormonal component. It can be precipitated by, stress, physical stress more so than emotional stress, but both can do it. So, you'll sometimes get a phone call about, a 45-year-old, she's running, she's gotten this central chest pain, and that has to raise your suspicion.
Okay.
But it can present like a blocked artery. This can happen in pregnancy. A third of these happen in pregnancy. So again, you have to think hormone mediated. And it's a tricky one to treat because, we love the blockage because we've got a great treatment for that. We stick in a stent, we relieve the obstruction. The doctor feels great, the patient feels great.
We have a solution.
Pain stops. Whereas with SCAD, with spontaneous coronary artery dissection, it's definitely under-recognised. It can be quite hard to pick up. So you really do need to have a high index of suspicion when you're doing an angiogram with these patients. B, putting in stents can cause more harm than good. So actually, sometimes once you start to put kit like wires and things into these coronary arteries, you can unzip them. They're very friable, so you can actually cause a lot of harm.
Right.
So actually, we usually try and treat them without doing something like that, unless there's a completely blocked artery high up
and
there's no blood supply. Exactly.
Yeah. Okay.
And they'll usually heal spontaneously, but it can recur.
Gosh. So, okay, let's get into our lifespan and our health span and what's happening in terms of our cardiac health. So when can heart disease actually begin for women? Can it begin in our 20s and begin very silently? Or when do we really need to be mindful of it?
Yeah, that's a really good question. When does it present versus when does it begin is a very different thing. Oftentimes, more often than not, it'll present kind of from our 50s on because we are protected to a degree until menopause. And after that, things begin to change. Unfortunately, it's coming to get us all. But it starts, the groundwork can be laid down much earlier. So I was recently part of a task force group writing another Lancet Commission. You mentioned the Lancet Commission on women and heart disease, but the one that I was involved in subsequent to that was in atheroma in coronary arteries. And I guess we, as in the medical community and for patients, I guess we're very focused on blocked coronary arteries and severely narrow coronary arteries that need to be fixed with stents. And that's what people want to know when they come to you. Well, are there any blockages, doctor? And actually, the focus of that article was trying to actually shift the focus off the end result of this process and actually think of the atheroma and the formation of it way upstream.
Yes.
Because that's when we have an opportunity to prevent things. So, you hear a lot about prevention. And the majority of prevention you hear about is primary prevention, which is defined as, the prevention of development of a disease if you have risk factors. So if you have high blood pressure, cholesterol, or diabetes, you're trying to control that to prevent formation of plaque in the arteries. But actually, there's a type of prevention before that called primordial prevention. And that's the prevention of the development of a risk factor. Yes. And this actually starts in the womb. All right.
Okay.
So you can't be blamed for that. Exactly. But, you know, if a mother, a pregnant mother has gestational diabetes or high blood pressure,
wow,
the fetus is exposed to that. And we know those fetuses are more likely, they have a higher rate of development of cardiovascular disease decades down the line as adults. We know from autopsy studies in babies that you know, fatty streaks in the aorta, in the wall of the aorta, can be seen, you know, within the first few years of life.
Wow, really?
So while you wouldn't see that if you were to do an angiogram, you wouldn't be doing an angiogram on a baby, but you wouldn't see that looking at an X-ray.
Yeah,
you know, but this is under a microscope, so you can see the groundwork is laid. So we have to be cognizant of this, and I think this is relevant for women too. You know, with our children, you know, there is a global epidemic of obesity and overweight, and it's all the same risk factors.
Yeah.
So, you know, the cheapest and most effective thing we could do globally, and this is another focus, I guess, of that article, is just control the things we know. So just control cardiac risk. So knowing about them is the first thing.
Yes.
And I suppose it's never too early to know. I mean, you know, having your cholesterol checked in your 20s, there's no harm in that. Having blood pressure done, you know, it's usually done opportunistically because you might be in the doctor's getting the pill or getting something else. And of course it should be monitored on the pill because that can raise blood pressure. But it usually doesn't cause symptoms. So unless you're getting it checked for other reasons, that's usually how people's blood pressure is diagnosed. So I would argue that every household should have a blood pressure monitor.
Right,
you know?
okay.
Blood pressure monitor that you can buy for less than €100 on Boots or Amazon. You know, cholesterol, I guess we certainly from our 40s, you know, definitely from our 50s, getting it checked. But even in our 20s, there are, you know, rare but important inherited conditions that can cause really high cholesterol, even in kids. I'm not arguing that kids should be starting to get their cholesterol done, because I think the trauma of that for the yield. But in our 20s, you know, no harm to get one cholesterol, and if it's fine, forget about it for 10 years or whatever. But some people have a crazy high cholesterol
because of genetic factors.
Because of genetic factors, so rare but important to know about. Needs to be associated with high levels of cardiovascular disease, heart attack and stroke down the line. And if you don't know about it, you can't treat it. Certainly as women from our 40s, we should be having these things checked. You know, blood pressure, diabetes blood test, HbA1c, and cholesterols. We should be getting that checked at least once. If it all looks okay, maybe leave it a few years. But if things are borderline, keep a close eye, institute lifestyle changes, diet and exercise to try and improve things, and check back. Did that help? Or, you know, am I heading
annually? Or what's optimum?
Yeah, I think, you know, annually is optimal. You know, if things are really good and you let it slip for a year or 3 years, I think if things are good, that's okay. But particularly around perimenopause, these things start to change. So I think 40s, you know, annually is no harm.
So before perimenopause, when risk factors might change or need a different focus, before that, again, in our 20s and 30s, what are the main risk factors for women?
So main risk factors for women, you know, I suppose it's healthy living. So it's diet, it's exercise, it's getting enough sleep. So the American Heart Association in the last few years has included sleep as one of the major cardiovascular risk factors. Right. Certainly one I am very guilty of, with years of call as a hospital doctor, and I'm just not
being a mom.
Good at sleep. And if I didn't have any of those responsibilities, I'd still be really bad. But look at the cholesterol, the diabetes. You know, this is all. You know, of course there are genetic components, but this is you know, you hear us say 80 to 90% of cardiovascular disease is preventable. And that's all these lifestyle factors. So
in earlier years, right?
Yeah,
if you focus on that earlier.
Absolutely. From childhood, you know, not giving kids, you know, healthy eating, preventing overweight, you know, not too much salt, you know, getting the kids outside, you know, they're not outside as much as we were when we were kids, you know. So that's the simple stuff that would make huge differences, but it's never too late to start. You know, so certainly getting enough sleep, not smoking. Getting exercise, you know, a heart healthy diet, or the Mediterranean diet. So I suppose low in saturated fats and high in kind of
still the guidance,
that grow.
Right?
That's still the guidance. You know, plenty of fresh fruit and vegetables, keeping kind of processed stuff to a minimum, lots of colour, anything that grows is not processed. It might be sprayed with something strange, but in general, the more processed food is, we don't know as much what we're putting into our bodies anymore.
So
we're not checking, and we're all working, and we don't have mom at home, and in a lot of situations doing the home cooking and that. So our diets have changed, and aside from the heart, we're seeing higher rates of bowel cancer in people in their 40s, and a lot of it is what we're doing with our exactly. Yeah.
I saw you had spoken previously about energy drinks. And the effect on young people's hearts.
Yeah.
So that's, I know that my teenagers drink them, and they're awful.
I mean, they're just like a combination of your loads of caffeine and loads of sugar. It's awful for the teeth, aside from the just that stimulant effect.
They're dreadful.
It's so crazy.
They're dreadful. Can I just go back to sleep? Because I think that's really interesting now that has been isolated as a pillar. Why? And what is, if we're lacking sleep, which, as you say, so many women are, or good quality sleep, what's that doing to the heart?
It's probably to do, well, I guess we know that when we're asleep, our body gets a chance to kind of refresh and regenerate, but also probably has a lot to do with cortisol and hormones.
Okay.
We know with heart attacks, they tend to happen. They tend to happen more in the morning. If you look at this, and that's to do with the circadian rhythm. That's when we have our big cortisol rush, and our cortisol is higher in the morning. That's when these things tend to present more. So I guess with lack of sleep, I guess we have that bit of an imbalance somewhere. Maybe putting more stress on our bodies and probably increasing cortisol levels, among other things. We're not giving our bodies a chance to regenerate, be it ourselves and our skin the next day and over time, unfortunately. So I think that's probably a lot of it.
That's so interesting. So do people have heart attacks while they're sleeping? Can that happen?
They can. No, absolutely. People can wake up with chest pain and come in, but we do see, if you look at numbers, throughout the day, and studies have been done of this, they're more typically early in the morning.
Okay. Yeah. So in terms of risk factors again, so high blood pressure, cholesterol would be the very well known ones. Are women's, is it a different profile for women than men in terms of high blood pressure and cholesterol? Are our numbers different? Do they need to be different, or?
Yeah, not necessarily. I mean, maybe they do, but we haven't defined that. I don't think so. I think, but it's a really good question. So still the typical pillars are important. We have some female specific risk factors, and I'll get into those in a second. Even with the traditional risk factors, our bodies probably respond differently. We do know that with high blood pressure, women are more likely to get thickening. We get more thickening of our arteries in response to blood pressure than men do. We also get more thickening of our heart muscle than men tend to get. So if you imagine, if you're pumping against a high pressure, and I say this to patients in clinic all the time, if you're in the gym pumping iron, your biceps gets bigger. It hypertrophies, it's the medical terminology. If your heart, your left side of your heart, is pumping against a high systemic arterial blood pressure, that also happens. Your heart is just a muscle, so it thickens over time, and over time it can cause heart failure. So we know that women's heart, the muscle does tend to get stiffer more so than men, and thicker for any given level of blood pressure. So we do seem to respond differently. But then we have some specific risk factors that men don't have to think about. So I guess pre-menopause, PCOS, polycystic ovarian syndrome, where there's kind of a relative androgen excess, so kind of an excess of male sex hormones and a relative paucity of estrogen. So we don't get that, protection as much. So we know that's, associated with metabolic syndrome and higher rates of cardiovascular disease in the future. Women, I guess, are protected by estrogen to a degree until menopause. That doesn't mean you can't get plaque before menopause. You certainly can. But after menopause, we see dramatic changes in the woman's body and in the composition of her cholesterol panel. We tend to get a greater distribution of fat around the visceral organs, so around the center of our body, unfortunately. And we know this is associated again with metabolic syndrome. And what I mean by that is the constellation, any combination of, high cholesterol, high blood pressure, diabetes. So that's kind of what we mean with an overweight. That's kind of, any combination of those is what we mean by metabolic syndrome. We see changes in the cholesterol panel. So maybe your cholesterol's been okay until now, during menopause, we tend to get an increase in our bad cholesterol, our low density, our LDL cholesterol, and a decrease in our high density or HDL, or good cholesterol. So the low density lipoprotein is the one that likes to deposit on arteries. So I guess coronary arteries are what I'm usually looking at, but it doesn't differentiate. It can be any arterial bed or neck, increased risk of stroke, anywhere around the body, legs,
or the brain, right? It affects the brain.
Yeah, absolutely. The carotid arteries up to the brain, exactly. And then the HDL is kind of the guy who likes to mop up after him. But I guess if you've less of the HDL and more of the LDL,
you're out of balance.
It's an atherogenic, lipid profile, which means it's plaque causing.
Yes.
All right. And our blood pressure also rises in menopause, so our arteries tend to get stiffer or constrict more, and we tend to start getting higher blood pressure. So a lot of changes that kind of are favorable for development of cardiovascular disease, and then we start catching up with the men. And then women are more likely to have connective tissue disorders, so things like lupus or Sjogren's or rheumatoid arthritis, these kind of inflammatory conditions. About 78% of these conditions are in women, and we know that chronic inflammation increases the risk of heart disease.
Yes, yeah. This episode of Image the Check-In is empowered by Boots. Boots pharmacists are with you for life. They are often the very first stop when it comes to advice, care and guidance. For all facets of women's health, at every age and every stage, Boots is here to help you feel informed, supported and empowered every step of the way. We are proud to partner with them to bring you the knowledge you need to future-proof your health. In terms of cholesterol, so is it true to think that if we haven't been monitoring it throughout our 20s and 30s, if we don't know our numbers because we haven't felt the need to go and have it checked, and then all of a sudden we're perimenopausal and the cholesterol has gone sky high, is it like, how do we know if it's been high for a long time before that? Is it presumed it's been high for a long time?
I guess we don't really know. When you have a first isolated high level, some people will say, well, it's always been great, and that's fine. You kind of know the duration, because what you're getting at is it's not just the number, it's not just it being elevated, but it's also the duration. Like, how long have you been exposed to that high cholesterol? And for most of us, it's not going to be high in our teens or 20s. And some people, it will be high in your 30s. And I guess if you have other risk factors, like maybe you're overweight, or maybe you have diabetes and you're going to be getting it checked, they're going to be paying close attention to all of your cardiovascular risk factors anyway, But people with a family history might be more likely to get this checked earlier. But a lot of us won't have had our cholesterol done in our 20s. I certainly didn't myself, and I'm in the business. But I guess looking back, there is no downside to it. Again, in our 30s, maybe we've had it done because of work medicals or that, but a lot of people haven't.
Yeah.
But that's why I think just early 40s, think about it. Do it once, see what it's like.
Yeah.
But if it is, your question, if it is high, we don't really know. There's no way we can go back and check.
Yeah. But it will have had an impact.
If it's been like that for years, we know that if you've high cholesterol or high blood pressure, any risk factor, even if you get it down to target, your future risk over decades is still a little bit higher than somebody who never had the risk factor.
Yeah.
It's still, if you get it down to target, a lot lower than if you don't get it down to target. So it's never too late to start checking these things and getting them down to target.
It's a really fine balancing act, isn't it?
Yeah. Well, you don't want to become neurotic either,
No, that's true. That's true. So just again, speaking about menopause and the hormonal effect. So our estrogen drops, then what happens if we're on HRT? Is that do we have safety from that, or just a degree of safety? What happens then after menopause?
It's a really good question. So in the past, I suppose there had been a big study done, the Women's Health Initiative, in people who had, HRT started quite late. And in these people, there was a signal for an increased risk of stroke and cardiovascular events. And I guess people had this fear, and I still often get patients, and less so with time, but I'll still get patients referred and say, is this patient safe for HRT because of this risk factor and that risk factor? And my feeling is, I'd say it's better to be on it, but within reason. I suppose the purists will say HRT is for symptoms and hot flushes and all those horrible things that affect a lot of people, and not everybody, with menopause. But we know that endogenous estrogen. So the estrogen that our body produces is protective against cardiovascular disease. So you have to think that exogenous estrogen, synthetic estrogen, would have the same effect. And I guess we're seeing more signals for this, that HRT started early, so around the time of menopause, not kind of in your 60s or 70s,
so sort of mid
started early, around the time of perimenopause, menopause, can have positive effects. Now, of course, we probably all want to be honest, and there are maybe vanishing reasons why we're, and lots of other reasons, I guess, and that's a discussion between you and your doctor, because there are, of course, like with everything we start, there's a risk benefit kind of, to way up, and of course there is a small but increased risk of breast cancer and other cancers, and obviously it needs to be in the right patients. If you have a family history of breast cancer, you're going to be more careful, and there are certain people who can't take these agents, but if started early in the right patient, it certainly does have some protective effect. Doesn't fully reverse all of those changes, but some protective effect.
So thinking of the big hormonal, I guess, transitions in a woman's life, so if that's menopause, perimenopause, what about in pregnancy? So do any of the pregnancy conditions that some women might have, like diabetes, gestational diabetes or preeclampsia, will they have any effect on cardiovascular health later?
Absolutely,
Once the pregnancy moment is over, I know it's a moment, but does it have a long
because you're right,
effect?
I think people have that, that was then, and that's, it's all done, I'm not pregnant anymore. But no, we know that people who have gestational diabetes or any hypertensive condition in pregnancy, be that preeclampsia, or even just you can develop hypertension in pregnancy. Or you could be hypertensive before pregnancy and have it diagnosed in pregnancy. But hypertension associated pregnancy is after 20 weeks. If you have it before 20 weeks, it is just hypertension. But if you have any of those conditions, it is associated with higher cardiovascular disease down the line. If you've had gestational diabetes, you're more likely to have diabetes in the future. So you have to be careful and try and modify those risk factors, keep the weight down, and keep an eye on blood sugars going forward. Likewise, if you've had blood pressure in pregnancy, you're more likely to develop blood pressure in the future, and again, it's not going to cause symptoms unless you're having a crisis where your blood pressure is over 200, and you might have symptoms of that. But for most of us, a lot of people are walking around with high blood pressure that don't know about it.
Yes,
really
that's true.
To get it checked. Equally, people will often be diagnosed with blood pressure and they'll say, but I've never had high blood pressure, doctor. And you say, well, it doesn't tend to develop in your 20s, and most of us, thank God, but it's something that happens over time as our arteries stiffen with age. So you can develop it at any time, and it's important to regularly get that checked.
So these big hormonal transitions in our lives, we have to pay attention to what's coming after those.
Absolutely.
And then after menopause, into our late 50s, 60s and beyond, what do women need to be thinking about then? I mean, the risk factors are they the same, and lifestyle modifications are still what we need to focus on?
What
about older women?
It's really the same thing. I guess people as they age are more likely to have blood pressure. So maybe you've moved from screening to management. And likewise with cholesterol, if we have diagnosed plaque on arteries, we're automatically kind of going towards tablets and statins. But I guess our first line for everything is going to be the lifestyle stuff. Then you're going to move on to tablet therapy if you can't do that with lifestyle alone. And really it's the same stuff that you're checking, every kind of 12-month-ish as in your 50s and 60s. And beyond.
And so what are the other therapies? So beyond lifestyle, how you can change or influence your risk factors to a degree, I suppose, but you can't completely change.
Absolutely. Look, there can be
what might have to happen
in a lot of these things. So I suppose if we take cholesterol, that's a big one. If you have high cholesterol, our first line treatment is, outside of you having had a stroke or a heart attack or, an event already, our first line treatment is, try and get it down. So modify the diet. Again, the heart healthy diet, cut out the full fat dairy, keep to a minimum, the junk food, the cakes, anything fatty, browner meats are fattier than kind of white meats or fish. So modifying the diet. Lots of, the bottom of that food pyramid, it's the same. It hasn't changed. Whole meal versions of bread, rice, pasta thing, they're lower in sugar. they're also less palatable, so you're less likely to overeat.
Yes, yeah, this is true. And they've more fibre, which is helpful
and they've
as
more
well,
fibre,
isn't it?
exactly, absolutely.
Yeah.
So helpful for bowel health as well. So that's the first step. And you know, if somebody's overweight, you'll often see a good reduction in cholesterol with losing weight. Likewise with blood pressure. It's the one thing, if somebody has kind of grade 1, so mild high blood pressure, it's the one time you'll avoid tablets. If they get the weight down, you'll often see that it will resolve. Now, if it's very high, you're not going to avoid that. But I guess if the dietary measures fail, then we would recommend medical therapy, and our first line therapy is a statin.
Yes.
And they get a bad press in the late media. And what I do say to people is every cardiologist above a certain age is on one, because we consider them life-saving drugs. I guess we see the other side of things, and we're fixing the blockages and seeing the heart attacks and the long-term effects that can have. But you know, that most of the trial data is with statins for lowering of LDL. They're the most effective tablet. Not
It always works, does it?
It doesn't always work. It will usually reduce your cholesterol to a degree. And of course, we are lucky to have a number of statins. And I suppose the two most potent ones are atorvastatin and rosuvastatin. So Lipitor and Crestor would be two common brand names. They're the most potent statins. There are many dose increases, but oftentimes you'll have somebody at their max dose and they still might not be controlled.
Right, really.
There has been only one add-on tablet for a long time, ezetimibe, and it comes in one dose, so it'll help, you know, it'll cause a modest reduction in cholesterol. And then there are some newer agents coming online that are maybe a little bit more expensive. And you know, I guess cardiology is one area that there's always a lot of research being done. So it is a very dynamic area, and more things will come online. And then I suppose blood pressure, you know, usually it is medical treatment, and it's often 1, 2, 3, 4 blood pressure tablets. You know, often one tablet alone won't
lifelong, right? These are like once they're
that's it. You know,
lifelong.
Sometimes people say, how long do I have to take that? And I say it's not a course of antibiotics. It's not going to cure your high blood pressure. You're usually condemned to it. Now you can choose whether you're going to take it or not, but usually once you go there, and I think that's why people maybe have a hard time. But once they're started on these tablets or don't like the idea of them, because usually we're kind of recommending
because it's constant management.
Exactly.
It's not,
And you know, we're very bad at it. You know, even in the Western world, it's high blood pressure. We're bad at diagnosing it.
Really?
So when people are walking around with it, because it doesn't cause symptoms, we're bad at managing it. So maybe we start a tablet, but a lot of people, maybe it's suboptimally controlled. I always like to know, if it was my blood pressure, I would want to know when I start a tablet or increase the dose, is it perfect now though? You know, there's no point in half doing it. You know, if you're on the tablet, you might as well be taking the right dose and that. So that's where the home blood pressure monitor comes into play. You want to know your own numbers, not leave it to your doctor who's busy and has a lot of other patients with maybe more potentially life-threatening things in the nearer future. You know, you should really take responsibility for your cardiac health.
Absolutely.
Know your blood pressure, know your HbA1c, the diabetes test, know your LDL cholesterol, your HDL cholesterol, and know your BMI.
So how do women know these numbers? So if we get a monitor for home, I mean, I think there's, not that there's confusion, but there's a lack of understanding about, okay, what do I need to test? What are my markers? What numbers are optimal? You know, what's good, what's bad. Feels there's more awareness about overall health in general, but I think it's hard to know still. Okay, what am I aiming for?
Well, that's a really good question, and I think it's hard. You know, I can tell you the numbers, but it's hard for people to remember that type of thing. And there are some really good, you know, I suppose Dr. Google can be a very dangerous thing. I say to people, if you're going to Google, you know, reputable websites like, you know, Irish Heart Foundation, British Heart Foundation, the American Heart Association, the AHA has really good data there, very easily digestible, where you'll find the numbers to aim for. You know, Mayo Clinic, Cleveland Clinic, again, if you're Googling anything medical, go to a medical website. Don't, you know, because I see, you know, I'll sometimes Google stuff myself, believe it or not, and you will see some crazy answers sometimes. And of course, then we have this AI thing at the top, and you have to look and see, well, where is it getting this information from?
Dr. ChatGPT is now, isn't it?
And some of that can be really accurate, and some of it can be really not accurate. So you got to be careful and make sure it's a reputable website. But in general, you want your blood pressure below 140/90, ideally below 130/80. You know, in an office situation with a GP or with us, you know, it'll often be a bit higher, and that's why we'll usually take maybe 3 readings if the first one's high. If the first one's good, brilliant. You know,
Why will it be higher?
people will, you know, people might have rushed. There might be
okay.
parking down the road, and you know, looking for parking outside a hospital. Everybody comes with high blood pressure nearly.
So
you know, you might
what's just happened to them?
Yeah, exactly. You might have just rushed in, like exercise. If you're standing, if you've rushed,
of
your
course.
blood pressure, it's normal physiological response. Your blood pressure needs to be higher to increase your cardiac output. But equally, people can be a little bit stressed, about maybe the outcome of tests or what the doctor's going to say, or just nervous about meetings. So you hear about white coat hypertension, and people can have blood pressure and white coat hypertension coexisting. And again, that's where the home blood pressure monitor or the 24-hour monitor with the GP really comes into its own.
Yeah. So, and I mean, also then there's all the tracking wearables, the Oura rings and all of those. Do you rate those? Do you think they're good?
I haven't heard the Oura ring, but certainly there are certain ones that we find really useful, and one is these ECG capable devices. So there's one that we use a lot, or recommend a lot, the Cardia Alive Core app. It's a little device about this size that you can buy for the back of your phone, and you can actually take a tracing of your heart with your fingertips. You can app, and it saves it as a PDF. You can email it into your doctor. You can save it for your consultation and show, well, when I'm getting palpitations, this is what my tracing shows. And you know, sometimes somebody will come into you and, you know, it really sounds like an arrhythmia. It really sounds like an abnormal rhythm that they describe. But it can be really hard. You know, you could put on a Holter monitor, 24-hour monitor every second day for a year and still miss the episode, but they're symptomatic if it's not frequent. So it helps us to diagnose these things. You know, equally on the other side, I guess it can drive people a bit mad, where they'll come in and tell you, well, my blood pressure monitor is telling me I have an arrhythmia. And, you know, if you have a few extra beats or an extra beat, you know, during your blood pressure check, that can manifest as an irregular rhythm, and of course it can pick up things, but you look at it and you'll say, well, your heart rate didn't change, and you know, you didn't have any symptoms, and so it's unlikely, you know.
So it can also create a bit of anxiety.
Absolutely, yes.
Makes it worse.
Yeah, exactly.
So can we really move the needle back towards better heart health if, you know, when we're a little bit older, and if we have some identifiable risk factors, like if the cholesterol has gone too high? Do you really feel we can take it back?
Absolutely. You know, I guess even in a patient who's had a heart attack or a stent or a bypass, the mainstay of their treatment going forward is prevention. It's prevention of the next event.
Okay.
So you don't want to see the back of the cath lab table for their own sake. And you certainly don't want to be sending them for repeat surgery. So it's damage limitation at that stage. I suppose you can't reverse the plaque, but you can stop further plaque developing. So, and patients will often ask me that if, say, we do a CT of their coronary arteries, so a non-invasive test to see is there plaque there already, and if there is, we're going to be super aggressive, even more aggressive. It changes our treatment targets. But people will say, well, you know, I'll say, well, here's a prescription for statin, and they say, well, will that get rid of the plaque? And unfortunately, we haven't discovered that therapy yet. I'm sure we will in time.
Yes.
But as of now, you know, gene therapies, you know, I mean, you know, there's amazing research going on, but we're not there yet. But what we can do is try and stabilize things, try and stop it from further growing, and try and prevent any little bit of that plaque chipping off, because it doesn't need to be a 99% narrowing. It can be a moderate narrowing to get a heart attack. So we want to stabilize those things and prevent further accrual and prevent a further event if somebody's had an event already. So absolutely, it's never too late, but I guess the earlier the better.
Yes, exactly. Are you excited about the innovations that are happening in cardiology? I mean, do you see, are there good things coming?
Oh, absolutely. I mean, I suppose even since I've started my career, you know, I guess when I graduated, I guess, you know, the only therapy for a narrowed aortic valve, you know, which we know once people develop a severely narrowed aortic valve, their lifespan shortens. The only therapy was surgery, and if you weren't fit for surgery, it was just managed. You know, it was just medications to keep you as healthy as possible for as long as possible. And now we have valves that we can put in through the leg. We're doing it in people in their 90s. You know, it's amazing. And I guess there are therapies coming down the line, and gene therapies being, you know, investigated and coming to fruition in areas like, you know, high cholesterol disorders, and you know, it's a really dynamic area. You know, again, in the area of stenting, you know, we first had bypass surgery, then we had balloons. Then we developed stents because sometimes after a balloon you'd have an abrupt closure in the middle of the night, you know. Then we had stents, but of course then arteries, the natural kind of healing response to the injury caused by putting in a stent would be sometimes to re-narrow. Then we developed stents with drug on them to prevent that. Kind of like anti-cancer drugs that would help prevent proliferation of tissue within the stent. Then in more recent years, I suppose bioresorbable stents have been looked at and did make it to clinical practice, but turned out not to be, I suppose, with the plastic-based devices, turned out not to be beneficial. There are now alternative devices based on metal bioresorbable stents being looked at. So who knows? But hopefully, it's I think it's very hard to develop. It's very hard to demonstrate an advantage over current stents because they've gotten so good. But we're still working on it, you know. And again, in medications. One thing we didn't talk about, lipoprotein(a), a type of cholesterol. As of yet, we don't have a treatment for it. But again, that's something we're doing trials on. It's a predominantly genetically determined particle. So I guess it's something we check outside of the regular lipid.
Yes.
It is a type of cholesterol, but a statin won't bring it down.
Oh, okay.
And we know that 70 to 90%, it's an inherited increased risk of cardiovascular disease, so heart attack, stroke, and in fact that valve narrowing. I just mentioned aortic stenosis. So if somebody comes in and tells you, a lot of my relatives died or had heart attacks young in their 50s, despite maybe not having had traditional risk factors like all being heavy smokers or diabetics or that, I'll always check that. Equally, if somebody comes in and maybe their father had a heart attack in his 50s, but perhaps there isn't a huge family history, often for reassurance, I'll check it. And if it's not, I'll say, well, you know what? The good news is you haven't inherited any increased risk. So you have the opportunity to prevent all of this. But again, it's a particle that we're investigating, and we don't actually know. We know LDL, if we bring it down with statins or whatever therapies, we know that translates into reduced risk of cardiovascular events, heart attack, stroke, death. We don't know actually with this lipoprotein(a), if we bring it down, does that reduce risk? You have to think, I'm sure it does, but we haven't demonstrated that yet. So we're looking at therapies to bring that down and then see, well, does it actually translate? For women, sorry, I'm interrupting you there, but for women, it's very relevant. We say everybody should have that checked once in a lifetime. For women, we've recently realised it actually can increase after menopause. So we should in fact have it checked again after menopause. There's obviously some genetic interplay there. So when I say 70 to 90% genetically determined, there's obviously some hormonal protection from the estrogen as well before menopause. But so
that's a huge consideration post-menopause.
Absolutely, yeah.
Oh, that's really interesting. And then actually speaking of older women as well, you mentioned earlier heart failure. That's, I don't feel there's a huge amount of awareness around that. What is that? I mean, the words heart failure, the heart is failing. It's failing over a period of time. Is it a progressive?
So it can be. It's
when
basically,
does it begin?
It can begin at any age, but again, like everything, it's more common with age. It's more common in people in their 60s and above. It can happen for a variety of reasons. I suppose if you've had a heart attack that maybe wasn't picked up on time, or maybe you didn't go to the hospital on time, that can kill. We say time is muscle, and that's why when an artery is fully blocked, it's really important people ring an ambulance and get into hospital and get it unblocked, because for all of the time, just like with the stroke, the muscle is dying. Muscle, it's not perfused and can potentially die. And once it scars, you can't reverse that process. So I guess if you've had a big heart attack or multiple heart attacks, that can cause a lot of scar and affect the pump function. But it can happen for other reasons too. You can have heart failure so heart failure basically means where the cardiac output isn't enough it's insufficient. So that can manifest by gathering fluid on board in the body. So shortness of breath, where you have fluid on the lungs, which can be worse lying flat because that fluid is distributing with gravity. So people may be telling you, well, I need 3 pillows now or 4 pillows, or in fact I can only sleep sitting up in a chair, because they're full of fluid in the lungs. Ankle swelling would be another sign. Now, not the ankle swelling that a lot of us, especially as we age, tend to get in the evening or after a long flight or hot weather. It's the ankle swelling that's not gone in the morning. So that persistent ankle swelling where you stick you press on your ankle and leaving a track. So they'd be the main symptoms, and I guess it happens men and women, and I suppose there's a different breakdown in the causes for it, but it can be associated with, I suppose, an increase with a lot of, I suppose, morbidity. So a lot of hospital admissions, gathering fluid on board. The mainstay of treatment is trying to keep fluid off, trying to keep people out of hospital, and of course trying to increase lifespan and healthy lifespan with the first two. If the pump is severely impaired, it can also be associated with dangerous arrhythmias in the heart. So sometimes people will have defibrillators implanted or special types of pacemakers to try and improve the pump function, to synchronize the heart, often with the defibrillator component. And I guess we did have a talk at our Women's Health Summit from Professor Mark Dare, a brilliant cardiologist who works with us and specialises in heart failure. And his talk was entitled Men Die Suddenly and Women Fade Away, because women and men, in the area of heart failure, men are more likely to get this fatal sudden arrhythmia. And this maybe is partly why we have this misconception about it being a men's disease. But men are more likely to get a ventricular arrhythmia that can be fatal. And that's what a defibrillator essentially treats. It shocks you out of a heart-threatening or life-threatening rhythm and restores sinus rhythm. Whereas women are more likely to, I suppose, decline quietly over time, or maybe repeated admissions and just slip away, rather than having that sudden cardiac death or sudden arrhythmia that kills them.
That's so interesting. And I ask because actually I have an aunt who is 89 and she has heart failure. But she attends a clinic here in St. Michael's on a Tuesday. She gets the bus up and down from her house. But she has heart failure. And I've always thought it was amazing that she's just, going about. Obviously she's a fine age.
And it's obviously well controlled, and that's the mainstay, and people can live a good life. But it's just important, I suppose, to recognise those symptoms, because often, even without going into hospital, we can change diuretic doses and maybe squeeze a bit more fluid. I kind of liken people to a sponge when I'm explaining it to them, and say, if you're full of fluid, we're trying to squeeze it off. It's also a fine balance between the kidney function, not overdoing it, and the fluid balance, But that's the mainstay of treatment. Keep people as management as healthy for, and they do a fantastic clinic in Michael's and Vincent's and
So I suppose, Róisín, what for women and understanding their cardiac health, and particularly through the hormonal transitions that we've talked about during their lives, what do you feel women really, really need to know? If you could speak to every woman now this podcast, what would you say to them?
So I think certainly, and I think everybody knows this, but the lifestyle stuff, the eating healthy, the getting the sleep, the exercise, the nutrition, the not smoking, and I think that's become less of a problem. Know your numbers and take responsibility for your own health. So find out your blood pressure. Brilliant if you buy your own monitor, but if you do get it checked at the GPs or in any medical setting, the pharmacy will do it for you. Ask the number. If you're told it's fine, that fine to me raises alarm bells. Was it good or was it fine? Because fine means I'm not going to, maybe we'll ignore that. See what it's like the next time. So know your numbers. Again, if you get your cholesterol done and you're texted, bloods were normal, actually ask, would you mind sending me out the panel, or can I please have an email of that? What's my LDL? What's my HDL? What's my HbA1c, your diabetes test? And again, what's your BMI? It's not a perfect test, but it's a good indicator in most of us. I suppose be aware that things change in perimenopause. Be aware that even though things might have looked great until a certain point, things can change over time, and it's really important to get these things checked. Particularly as we age, 50s, 60s, get them checked once a year. And I guess any of those symptoms that we discussed earlier, absolutely to get checked out, particularly exertional symptoms when you're exercising. It doesn't need to be in the gym. When you're walking up a hill, when you're pushing it, symptoms brought on by that and relieved by rest are red flags for us.
I think so much of that message has come through a lot of this podcast series, actually, for women.
Really,
It's about understanding, knowing your numbers, advocating for yourself, especially. I mean, I know I recently I moved GP because I used to go for blood tests. You know, you get a text back saying, "Oh, everything is normal."
Yeah.
And I was like, "No, can you explain it to me a little bit more?"
Yeah, which is great. At least you know somebody's looking at it. Better than not hearing anything, but still you want to know
a little bit more. Yeah,
and I'm sure they'd be happy to provide.
Oh, absolutely, absolutely. And I just moved to another GP recently, and she gives me all of the information, and I love it because I love the data.
Yeah, exactly. I think it's really important. And equally, when you go to a doctor, like when somebody comes to see me, I want to know all that stuff.
Yeah.
You know, and please bring it, you know, and I'll ask you to bring that stuff because otherwise you're not getting as much out of the interaction.
Absolutely.
So I think that in the dark to a degree.
Yeah, that advocating is so important.
Yeah, absolutely. Yeah.
I think that's a really key
And I
message.
guess for women as well, you know, with the children, think of it early, like because it is 80 to 90% preventable, and that's all lifestyle.
Yes.
The other 10%, 10 to 20% genetics, but for the most part, it's preventable, and we're not doing a good job of it.
Yeah.
Worldwide, but
women's health is more important than the NCT.
Yeah, absolutely. Yeah. Maybe if we brought in some kind of law or kind of cut-offs where people have to do these things, people would be more, for the insurance companies or that, people might be more prone to getting them done. But take care of yourself, otherwise you can't take care of other people.
That's it, exactly. Róisín, thank you so much for this conversation.
Thanks so much for having me, Ellie.
Thank you.
Thanks very much.
Thanks for checking in with us. We hope today's episode gave you insight and clarity. If you enjoyed it, please like, subscribe, or share it with a woman you feel needs to hear it. Image the Check-In is empowered by Boots and sponsored by Samsung and Waterstone Clinic. Thank you to our partners for making these conversations possible. And thank you for listening. For more expert advice and real women's health stories, visit the Image Women's Health Clinic on image.ie and follow us on Instagram. And until next time, take care.